This is a 50-year-old female patient with a diagnosis of right hand carpal tunnel syndrome. And this video shows a surgical procedure of carpal tunnel release and median nerve decompression under local anesthesia. I am Dr. Anil Kumar, consultant specialist orthopedic surgeon. So here is the patient is prepped and draped, and this is a local anesthesia mixture of 1% xylocaine with adrenaline and 0.5% marcaine. So I usually give local anesthesia first, a wheel elevation right just proximal to the distal palmar crease in the volar skin of the distal forearm, and after waiting for 2 to 3 minutes through the same spot where the initial injection was given, now you give the injection and in subdermal subcutaneous tissue from proximal to distal. As you inject, as you drive your needle under the skin, gradually give the injection first and then gradually push the needle distally, and you can see the blanching of the skins. And I usually bend the needle at about 45-degree angle. And after sufficient injection fluid is placed in the subdermal region, now you can turn the needle on 180 degrees and inject just on the surface of the carpal volar ligament, as well as just under the carpal volar ligament or anterior to the median nerve. Do not puncture the median nerve, or should not be given into intra-nerve injection intraneurally. As soon as you puncture the volar carpal ligament, you can feel the loss of resistance in the needle, and withdraw the needle and then give the injection. And a vertical skin incision is made just distal to the distal wrist crease, and I usually do not cross the incision proximal to the wrist crease. So the skin edges are retracted, and any excess local anesthesia and bleeding is mopped, and incision is deepened. So first, after the skin incision, you cut through the subcutaneous tissue, fat, and also palmar aponeurosis. And usually you find to the palmar aponeurosis. Now usually you encounter the volar carpal ligament just under the palmar aponeurosis, and you turn the blade upside down and then use the blade to cut through the distal part of the volar carpal ligament. And I usually use my left hand finger to press the carpal ligament against the sharp margin of the blade, scalpel blade. So you can incise the volar carpal ligament, and then the retractors are repositioned, and then the proximal part of the volar carpal ligament is divided vertically. Here I'm looking at the epineurium of the median nerve. You can see the median nerve right under the volar carpal ligament, and there is some thickening of the epineurium of the median nerve. Again, the epineurium is incised carefully without damaging the median nerve. And the final chuck is made of the median nerve, and also release of the volar carpal ligament. And also check for any active bleeding to prevent any hematoma. So I usually use 4-O-proline as a single mattress vertical stitch. Two mattress intermittent mattress stitches are used to close the skin and subcutaneous tissue as a single layer. Which provides a very good hemostasis and prevent any hematoma. Stitches are left for usually for 2 weeks. At the end of 2 weeks, I see the patient in the clinic for removal of the stitches and to monitor wound healing. And during these 2 weeks, I'll usually advise the patient that patient should not get the hand wet until this wound is completely healed. So after the skin sutures, skin is cleaned with saline, and then a mild compression and firm bandage is applied, and also advise the patient that you expect some mild swelling of the fingers, including the thumb, which usually lasts for 24 to 48 hours. And also advise the patient to continue to exercise the fingers as tolerated.